Welcome to the Low Carb MD Podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low Carb MD Podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Hello and welcome back to the Low Carb MD Podcast. Tro, good to see you, man.
It's good to
We've
see
both
you
been too busy.
It's good to both of us are too busy. You're out there. Did the conference happen in Arizona, or is that?
Yeah, it was pretty awesome. We had a great time. Good
That's
turnout. A lot of people online. Yeah, it was fun.
That's
Good
awesome.
stuff. Hal Cranmer, all the good Arizona people were there. A lot of fun.
Yeah.
We're talking about how to fix medicine and how to not end up in nursing homes. So as you get older, Tro, you'll understand what we're talking about. But right now, you're still too young.
Listen, I'm trying to stay healthy myself. I'm trying to keep my patients healthy, and I'm super excited today because we have somebody here who came from the remote monitoring world, which I'm super excited to hear about. And he sort of broke free, and now he is, really helping people with direct primary care and really get healthy. So I'm super excited today, Brian. Why don't you introduce him?
Yeah, he's a great guy. We actually, if you can go back and look at Life's Best Medicine, we're talking about how do we fix healthcare. It's a big nightmare. And well, Andy, tell your story. We'll go through it and we'll talk about CrowdHealth and what you're doing and your experience in healthcare and how you got to, like, your personal experience. And because I know the story, so Troy, you could ask all the questions, but I had the same kind of experience in my life too, and just say, what are we doing here with health insurance? So Andy, welcome, good to have you.
Yeah, thanks guys for having me. I'd be happy to talk about my first round in healthcare was remote patient monitoring. So I ran a remote patient monitoring company for about 10 years. And we were actually one of the first ones in Texas to do to do patient visits over video. This was 2008, I believe. And you'll laugh at this, where the video calls that we had, given that our members were a little bit older, they were only on copper lines. And so it was dial-up video. So you remember AOL was like beep, like you had to do that to get on video. But I'll tell you a quick story because I think it'll highlight just the craziness of our system. We were doing a diabetes management program down in the Rio Grande Valley of Texas, and so the vast majority of this population was Hispanic, and so we were working with a health plan down there to help their diabetes patients, and so we were getting together with them a couple times a week over this, old school video equipment. Like I said, you had to dial up to, and as such, given the population, the majority of them were eating, 3 tortillas with every meal. And so one of the first things we asked them to do is like, hey, would you cut down your tortillas? And they were like, I've had 3 tortillas with every meal since I was 5 years old. You're not going to have me. And then plus, that's not sugar. Well, what are you talking about? Da da da. Right. I said, okay. So why don't you have 3 tortillas with every meal this week, and we'll monitor your blood sugars, via our remote patient monitoring equipment. And then you have 2 next week, 1 the following week, and none the following week after that. And so in essence, what we showed them on a graph is their blood sugars, were going like this, as they were reducing their carb intake. And, these people were in the, 8 to 12 A1Cs. And over a period of a year, 3/4 of them got below 6. 1/4 of them just didn't want to comply with kind of the program that we had stuck them on. And then we went back to the health plan after a year and we're like, look at these A1Cs. They're amazing. They've gotten down 3, 4, 5 points. And so we thought we were going to be like heroes. And my head of sales walked in, just told him, I gave him all this data, and the chief medical officer said, we're going to cancel the program. And we're like, what? You're going to cancel the program? We hit all of our metrics. Like, what are you talking about? And as we dug in a little bit more over the following month, what we found out is we had done too well. Their medical expenses has gone down too far, and they were prepping for the medical loss ratio rules that the Affordable Care Act was supposed to put in. And so if they actually saw their premiums decline, what would have to happen is they'd have to start cutting administrative expenses. They'd have to start, cutting salaries, all these things. And so they actually, canceled our program because we were too effective in reducing the diabetes in their population. They weren't going to get paid as much as they would have liked if their members do have diabetes. I mean, it is the wackiest thing.
Well,
and I was like, my head exploded when I heard this.
My head's exploding right now. You're going to have to give a little bit of backstory, and I think you can probably do it better than myself or Brian. Can you give the listener a backstory? They don't understand, and I don't think it's easy to understand for people outside of our worlds, how insurance companies wouldn't want to decrease costs. So maybe can you just talk about how that started? I know and you could probably explain it better than we can.
Yeah, sure. Happy to. Yeah, so let's put together a fictional health plan that has $100 million of premiums that are given to the health plan. Under the Affordable Care Act, that health plan can only use 15% of that for administrative costs and profit. So yes, they're taking 15 million of that 100 million that they can actually use for their salaries and all these kinds of things. And so, how do you increase that 15 million by 10%, 16.5 million, right? Your premiums actually have to go from 100 million to 110 million. So now you have another $1.5 million if your premiums go up for profit, for salaries, for the Maui, brokers parties that you're throwing, all these things. And so health plans actually have an incentive for prices, for premiums to go up. If you look at that, and that's compelling, but think about it the other way too. If you have 100 million of premiums and you want to decrease your premiums to 90 million, then your amount that you have to spend goes from 15 to 13.5. And so you now have $1.5 million less that you get to spend on people and salaries and parties. So you actually have to start cutting people out of your organization if your premiums go down. So there's all the incentives in the world for health insurance plans to actually see premiums go up versus premiums go down. Premiums go up, more parties, more people, more bonuses. Salary premiums go down, less people, less bonuses, less parties, you have less money to work with. And so in this situation, the health plan was actually seeing premiums go down, or the cost, the expenses go down too much. And they're like, no, we're not going to do this. And so it was one of my introductions to the perverse incentives of health insurance.
It's mind-blowing. It's super mind-blowing. And for me, I didn't even know that part of it. I never thought about it in those terms, because if the absolute numbers go way up, then we have more money that we can spend, right? Because you can only take 15% or whatever it is now. Exactly. And so then the other thing was, when I resigned from my old position after Tro wrote me into direct primary care, I had to sit down with the head of the HMO and we had this discussion. And I said, do you know how much money I've saved you in the last couple of years by preventing diabetes or reversing, getting people off insulin? Your number one cost is going to be bypass surgeries, amputations, dialysis, blindness. All these things are from diabetes. And he said, no, you're costing us money, because if they get those diagnoses, we get paid more by the federal government. And now Doge today, I just saw they've been there for 3 hours and they're like, oh, we found $100 billion of fraud and waste. And you go, oh my gosh, this is insane. What do we do? How do we fix this healthcare problem?
Yeah. Well, I mean, when people say healthcare is so complex, I was like, no, healthcare is not that complex, actually, because you have the buyers of healthcare, health insurance plans, they want the price to go up over time. You have the sellers of healthcare, which are these big hospital systems and pharmaceutical companies. They want the price to go up over the time. And so you don't need a PhD in economics to figure out if the buyers and the sellers of a product want the product to go up. Guess what? The product is going up because there's no other forces that are pushing those costs down, because there's no incentive to.
I think one of the things that the average person doesn't understand is exactly what we're talking about here, that the economics are all out of whack. And that's the top level economics. But there's a whole nother layer of perversion when it comes to insurance because there's bilateral gag orders. So the other thing needed, for a good market to work, everybody's got to want to win. And when right now, everybody's winning at the expense of the taxpayer and the consumer. And nobody's on the hook for actually producing any sort of healthcare results, right? It's an occurrence-based model. So forget the economics, which you just described perfectly. The macroeconomics means, the pharma, hospitals, everybody wants higher prices, and so does insurance companies because they get paid more, which they're the main customer to these, to these entities. The other part that makes this so perverse is they have made contracts with each other saying, you will not disclose what we're paying we're not going to disclose what we're paying each other. So you can't, effectively price shop as the consumer. So say you're like, well, I want out of the system. I'm going to go take my dollars and spend it, a little bit wiser, still maybe with insurance, but I want to pay less. I have a high deductible. I want to pay less. You will not get pricing. If you call your local doc and say, how much does a visit cost? They're not going to tell you, right?
They don't know. People don't know. I can ask a surgeon, how much does it cost to do an appendectomy? Like hospital, they don't know. They have no idea. They go, I just bill this. They don't know what they're even getting reimbursed. I mean, there's like, it's the craziest negotiation system ever.
Well, let me give an example that's near and dear to me. I had a family member who recently got injured. Okay, emergency room, went used their insurance, had to get surgery. They went for follow-up, right, to see that doctor, and apparently that doctor doesn't take their insurance. So he gets to the office, and the office says, well, we don't take your insurance. And he's like, okay, well, I need to follow up with this doctor. He just did my surgery. Can you tell me what I need to do to get follow-up care? Like, how much am I going to have to spend? The office says, well, you need to talk to billing. He goes to billing. He's like, okay, I got time. I'm going to go to billing. He goes to billing. Billing's like, nice to meet you, sir, but we don't know how much he's going to charge you. And then he goes back to the office. He's like, hey, I went to billing. They're like, well, you need to go back to billing. He's like, I'm not going anywhere. Tell me how much it's going to cost to get my stitches out and be examined. And this is the nature of healthcare. The average consumer is getting screwed. And nobody likes it. The people don't like it. The patients don't like it. And the docs don't like it. So what are we going to do? I mean, did we are there any other like hidden areas here, Brian or Andy, that you think are worth mentioning about how messed up the system is?
Well, I'll just tell you from my experience. Andy and I talked about this last time. My daughter blew her knee out. She went, we had to get an MRI, go in there. I'm like waiting and, took her to the imaging place and, they go, oh yeah, your copay is going to be $550 for the MRI. I'm like, well, crap. What do people without insurance? How much are they paying? Like I have insurance. And she goes, hold on. She comes back. She's like, $250. I was like, if I pay you cash, it's $250. But if my copay for my insurance is $550, so I save $300 by paying you cash, right? Like, here's my Amex. And I go, okay.
Yeah.
But it doesn't go towards your deductible. You understand? I'm like, I don't care. This kid's always healthy. Like, okay. But you look at that. And I think the other big issue is, and this is where Andy fits in, is because this is what we deal with. Like, you have to have, like, I just saw a lady, she's a real estate agent. She makes good money. She has no insurance. She goes, I'm coming to you because I have no insurance. I was like, that's not a good plan. That's not a good plan. Because you need to call Andy, you got to call it, because if you get hit by a truck, even though you're healthy and you're fit and you don't drink, you're taking care of yourself. Some things are outside of your, right? Outside of your, what you have control over. You get hit by a drunk driver and who's going to pay for that? Like, you're in trouble. So, those kind of things you go, okay, what do you do to, make sure you're taken care of? But on the other side of the coin, she's saying, look, it's going to cost me, like, to get Blue Cross, whatever insurance, it's going to be like $1,800 a month for me and her son, and so she's like, what do I do? Okay. You get a high deductible in case you do get hit by a truck, and then you pay cash for the rest of it and you save money.
Yeah, but even high deductibles nowadays are not inexpensive. I mean, I went to healthcare.gov just this year just to see, curious what me, my wife, and my two girls would cost, and I think it was like $1,300, and the deductible was $18,000. And so in essence, I'm paying 30 some odd $1,000 before the health insurance plan pays $1. I'm like, this just doesn't make any damn sense, you know? And Dr. Cho, you asked, some of these other hidden things. The thing I found out, just about 6 months ago from a guy that works at the health plan is that the hospital systems, when they negotiate with the health plan, they tell the health plan they can't navigate to different hospital systems based upon price. So, if the hospital, if the health insurance plan has somebody in their case management program, they cannot use price as one of the ways to navigate their members to specific doctors or hospitals within their system or within that city, right? So, I live in Austin. We have St. David's and we have Seton. If the health insurance plan knows of somebody in Austin that needs to go get help, they can't navigate them to the low cost provider. That's against the rules within these hospital system contracts. So it's totally, I mean, just crazy town when you get into those pretty incestuous relationships between the health plans and the health insurance, or the health plans and the hospital systems.
Yeah, and also meds. You look at meds, you go on goodrx.com and you look, I don't have any affiliation with them at all, but you look and like, okay, CVS this much, Costco this much, and you look at different drugs, you're like, oh my gosh, it's a tenth of the price over here, but this drug is 3 times the price. And you look like, you send each drug to a different pharmacy so that you can get the best if you're cash pay, And the other crazy thing is, I have people who go in and they like a Zithromax Z-Pack. They go in and pay cash, it's like $3 or $4. They go through their insurance and it's a $20 copay. Like, this is crazy.
I'll tell you a crazy one. We had a woman with non-Hodgkin's lymphoma, and the med that she was supposed to take, or she is taking, the getting it through the hospital was going to be $40,000 a month. We went directly to the manufacturer, the pharmaceutical company, and got it for $2,500 a month. I mean, you rip out all the middlemen in this, rent-seeking industry that we're a part of, and costs go down substantially. And we're doing that not only for pharmaceutical companies, but for pretty much every service that our members are going to get. You rip out the middlemen, you go directly to the doctor, directly to the pharmaceutical company, directly to the facility, and you can get these things significantly lower than if you were to use health insurance.
I want to harp in on something here because I think it's important. One of the things that insurance does, which is essentially what they've reduced to, is covering sort of those catastrophic costs. But because of this bi-directional lack of transparency, I mean, you hit the nail right on the head. What you're doing is you're navigating around all of the middlemen, and you are exposing a huge difference in price. So when you go to the manufacturer directly for that drug, you're spending $2,000, whereas the upcharge for the facility fee and the administration or whatever is like $20,000. And there's a huge spread there. And when there's that huge of a spread, I mean, there's an opportunity to save people money. The problem is we're still by law sort of encouraged to get insurance, which is, I think, a huge problem. And I want to add to that, to what you just said, this huge spread. When we order lab work, we have a pretty expansive hormonal panel that we order on our patients. If we send them to their insurance, it's a $3,000 bill they're going to get hit with. We've contracted with the same labs for $350 for our employee wellness cohorts. And they wanted to stipulate that we can't send our patients to get that pricing if they have insurance. They wanted, and we wouldn't sign it. So just think about that. That's the spread. The real cost is probably around $350, and they're charging the insurance companies $3,000. And I guess this is where your company comes in. Am I right? Or is that, do we hit?
Yeah.
Have we created?
Absolutely.
I think we've described the problem enough, right?
Yeah, in essence, what we're trying to do is we're trying to enable people to pay cash, credit card, whatever, directly to their healthcare provider without the need to have health insurance. And that's what our system, our platform is trying to do, and has done really, really well for the last almost 4 years. Over the last 20,000 bills, we have 10,000 members who've signed up to join our community. And so in essence, what happens is Dr. Tro breaks his arm and it's $5,000. We're going to ask him to pay the first $500 of that. And then we're going to go to 45 people in the community and say, hey, will you send Tro $100? And if they say yes, that $100 goes from their account, whatever form of payment they gave us, to Tro's account. And at the end of the day, Tro's going to have $4,500 in his account plus $500 that he's contributing to go and pay his doctor directly for that service. And as a result of that, his doctor is giving him way better pricing than, if he were to have to go through health insurance. And in fact, for our members, we're getting about 50% better prices for our members than what United Healthcare pays for large medical bills. So we're getting somewhere around 120 to 150 of Medicare, whereas the health insurance plans are paying somewhere between 250 and 300 of Medicare for these large procedures. So that results in, significant savings. I'll give you one quick example. We had a guy, and this is kind of back to what you were talking about in terms of you couldn't get hit by a truck. We had a guy who was in Montana, bear country, wolf country. He had a 44 in his revolver in his holster, and he's out fishing, catches a fish, leans down, the gun falls out of his holster, hits the hammer perfectly, bullet goes off, goes into his calf, out the back of his calf, into his thigh, out the top of his thigh, into his chest, and out the back. Totally took out his small intestine, gallbladder, nicked his liver. He looked down and he said he saw green stuff coming out. I'm guessing that was bile or something coming out of his chest. He had to get medevaced out from that stream. So I had to have a helicopter come in because he was 2 hours from the local hospital. He went to the hospital, went into a coma for several days. He had to drive home from Montana to California because they wouldn't let him on an airplane. He got sepsis on the way. He was in sepsis for 3 weeks. I mean, this is a bill that's approaching $1 million. And we were able to go in there and negotiate directly with these hospitals and got it down to about $200,000, which was funded by the community, very, very quickly. And so this can work for very large bills, like I just mentioned, or small bills where you go to your, direct primary care doc and pay for those types of bills. So yeah, in essence, what we're doing is we're trying to enable people to pay in cash for all their healthcare service, and as a result, are getting way, way better pricing than your health insurance.
You mind if I challenge you? And I don't mean to be contentious.
No.
I want to like play the devil's advocate here, even though I love what you're doing.
I love it.
I just, this is completely friendly, but I'm going to be hard hitting here. So one of the first things that comes to my mind to do this really effectively, and you've probably thought of this, like what happens if you get 3 of those, right? What happens if you get 3 of those? Are you getting insurance for sort of like $5 million in expenses and up? I don't know what your total is, but are you guys insuring like some top end, so that you could cover people in case shit hits the fan? Like what happens?
It's a great question.
Yeah.
It's a great question.
Help me understand that. Yeah.
Yeah, so let me go into kind of how the bills are paid. So we ask all members to help somebody else in the community for up to $140 a month. So that's money that's going directly to somebody else. So in my example with Tro, I asked people for $100. We're only going to ask up to $140 every month. But in reality, all we're really asking for with this month, we're only asking for 80 of the 140. So, about 45% less than what we could ask for because bills are so low right now. So when bills jump up, we then can flex up to that 140. We will never ask for more than that, but it gives us significant, opportunity to go and fund really, really big bills, right? And so instead of having a big pool of capital, I call it fiat, like fiat capital sitting in a bank account that's declining every year because of the money printer, a super inefficient way of holding capital. What we do is we say, we're gonna charge you here, but we can charge you up to here. And so it gives us some flex up and down depending upon what's going on with the bills. So that's number one. Number two is this big event that I just talked about. That happened in July. We found out about it. And I was like, hey, this is going to be a multi-$100,000 bill. And so we started funding that in August. and then September, and then October. We didn't even get the bills until October, but we had already pre-funded that. And then those bills, it takes about 3 to 6 months to actually negotiate those bills with the hospital. So I've got another 3 to 6 months after that to continue to fund those bills. And so what happens is that in the kind of basic finance, you don't have the big choppiness from month to month. In fact, what you're doing is you're stretching it out over a period of time, because now we have up to 12 months to get those bills funded. And so it allows you to stretch that out. It's like going and buying a house. Most of us don't go and buy a house for cash. We stretch it out over a period of time so that we don't have a choppiness in our cash flow. And so I could have 10 of those happen today, and our community would be totally fine. And we've had, 4 or 5 NICU babies all hit at one time, and we had to flex from that 80. I think we got up to like 125 or 130 or something like that in those months. And then we got those bills paid off and it went back down. So it allows us to flex up and down depending upon what's going on in the community. And so it has been, we've had big ones happen, multiple big ones happen at the same time. And the community does have to flex up, but they get that. They understand that they have to flex up to 140. I say budget for 140. If I ask you for 80, great. You have $60 more per month. Go take your wife out to dinner, or go buy a ribeye or something, right? That's the way that we operate, and it's worked, great over the last almost 4 years.
But do you insure over that top 140?
We do not insure over the 140 because there's no need to. There's no such thing as a $5 million bill when you're paying in cash. There's probably not even $1 million bill if you're paying in cash, because we're getting so much better pricing than health insurance plans that they just don't happen that often. There's another health share that I was talking to, and they've got about 50,000 members. They've been around for 12 or 13 years. They never have had a bill over $1 million because they've always been able to negotiate it down significantly. When you're with United Healthcare and you have a contract, which are, for stupid prices, they're contractually obligated to pay this, egregious bill. I'm going in as an uninsured patient. So I've got all the negotiating power in the planet, because the hospital, whoever the service provider is, knows they're not going to get $1 million from me. They're going to have to give me a price that's a lot more reasonable, because then, they have this decision to make. They can put me into bankruptcy if they want to, but that's a terrible PR. Hospitals don't want to do that. So they're actually going to negotiate. And we actually have lawyers.
They don't get paid. They don't get paid if they put you in bankruptcy. They just get
the satisfaction.
And
we actually have lawyers on our team that negotiate on your behalf, so that if the hospital takes the next step and says, "Oh, I'm going to sue you," and they're like, "Okay, great. We have attorneys that will take care of it for you." And so the members are okay with that. So it's worked out really, really well with these very, very large bills. So
with this 140 a month, is there an additional cost of being a member every month? And then that's the flex a part of it?
Yeah. So it's two bills per month. $55 is like a subscription fee that comes to me. And so that aligns me with our members. We just talked about the perverse incentives of health insurance. Like, I don't want to have to collect this much, and however much goes out the door, I take the difference, because that creates perverse incentives. So I'm getting a subscription fee, and that then motivates me to make the crowd bigger, the community bigger, keep people healthy so they stick around longer, all of those things. So that every month on the anniversary of your start date, we charge you $55 per person. And then on top of that, we will ask you once per month to help somebody else out in the community, up to $140 per person, or $420 for a family of 4 or more. And that's the max we will ask you. And then the beginning of every month, we're going to say, hey, so at the beginning of this month, we said, hey guys, we're going to charge you $80 if you're a single person, or we're going to charge you $240 if you're a family. Because my max is $420 on the family. So I'm not asking for all of it. So, and then that's what we're going to ask you this month. And, like I said, that's worked out, really, really well I think we've been in existence about 40 months. So for the last 40 months, it's worked really, really well.
So how does it work for a person who's I have a direct primary care doc, right? Do I just pay cash? I just do that out of my pocket for the direct primary care doc, and then you're covering me for the major stuff?
Yeah, but we will also allow you to submit $300 per person per year for your DPC membership. So, that's not a lot, but it's enough to reduce it a little bit. So, if you have four people in your family, you can submit up to $1,200 a year for your DPC doc.
Oh, great. And then labs, like if they're going to order labs, do you have specific labs that you recommend they use, or how's that work? Because it's funny because one of my patients was telling me, goes, "Oh yeah, I just submit my um labs and you guys cover it."
Yeah. So if you have a DPC doc, they usually have really good lab prices. They've got good contracts with the local, lab. If not, then we've got some other partners. I think you can go to Own Your Labs, which is, I think that was it Dave
Dave
Friedman
Feldman.
or
Yeah.
Ded Feldman. Thank you. We send them to Own Your Labs, or Laboratory Assist is another one, or Jason Health is another one. They're all reasonably priced, not awesome, but reasonably priced. So we just send them to one of those folks too. All we ask is they don't go directly to the lab because you're going to get screwed on price. Go through one of these partners that we have, and they typically can get labs for really, really inexpensive.
So is the goal, like, is it better for the crowd to have healthier people, or is the goal to get sick people and get them healthier? Like, what's your ideal person signing up right now?
Yeah, I mean, I think right now we've got a lot of people who are healthy who, want to fund other healthy people. I mean, there's a little bit of a view here, not a little bit, a lot of a view here is like, look, if we're taking care of ourselves, if we're metabolically healthy, then we should be paying less. And we shouldn't be paying for the people who are not metabolically healthy. And so we've got a group of people who are pretty metabolically healthy, and as a result of that, the bills are really, really low. We're also starting in March some incentives to get metabolically healthy. So if you have a DEXA scan and have a visceral fat, level in the bottom 25%, then you get 10% off. If you have a fasting insulin below, I think it's 5, maybe it's lower than that. But if you have a fasting insulin under 5, then you get another 10%. And so we're building in an incentive program where you're actually get a discount if you are metabolically healthy. So both incentivize people to join us who are metabolically healthy, as well as incentivize the people who are with us and aren't metabolically healthy to get metabolically healthy. So, I mean, it's one thing if you change the cost curve, just the price per service. I think it's another if you can change utilization. And what I've said many times in a lot of these podcasts is like my end goal is for us to have the healthiest 65-year-olds going into Medicare. The last I saw was like 70% of folks who enter Medicare have a chronic condition, and 15% have 6 or more chronic conditions. Ultimately, I want our members to be 80 years old playing wiffle ball in the backyard with their grandkids. I mean, that's to me was what thriving looks like. So we're trying to incentivize people and educate people on some of these metabolic health biomarkers. In addition to that, we actually do a quarterly special where this quarter it's DEXA scan. So if you go get a DEXA scan, it's fully fundable by the community. Next quarter is VO2 max. The following quarter is coronary artery calcium score. The following quarter is fasting insulin and LP(a). And so we're trying to educate people on what all of these things are, what they mean, and how they impact their body. And I think through education, we are getting people to be more metabolically healthy. We're going to start tracking this stuff. So what is your visceral fat levels this year? And then let's track it for next year. Let's do better next year. And so that people can actually see that progress over a period of time. So that was a long-winded way of saying we got a lot of metabolically healthy people, but some not metabolically healthy, but we're trying to get them to the metabolically healthy state. The only kind of caveat to people who join is if you're obese, you're not welcome. If you're a smoker, you're not welcome. And if you have a pre-existing condition, then you have to own your own pre-existing conditions for the first 2 years before the community will help you out with it. And so the reason behind that is when we started, we had a bunch of people come in and have knee replacements, and like they got their knee replacement and then they bounced out They got their hip replacement and they bounced out. And like, we just can't do this. Like, at some point, like, you got to be a member of the community to get some of the community members to help you. But we do have a bunch of people with like type 1 diabetes that came in, and they're like, man, I'm saving so much money with CrowdHealth, and you guys are finding me insulin for so much less than what I was getting it for my health insurance, that it just makes sense for me to be a part of CrowdHealth. And we're like, awesome, welcome. And so they're paying for their own meds and supplies with the money that they're saving by using CrowdHealth, as opposed to one of these other trash health insurance plans.
So if they have obesity, they can't join.
Right now, if you were over 260, you can't join unless you have significant muscle mass.
Got it. Okay. And this is for everything, or this is the carnivore crowd?
This is for everything.
Got it. Okay. And
so if you have significant height or significant muscle mass, we make some exceptions, just because we got a lot of CrossFit guys who are, really beefy,
like Sean Baker, like someone like Sean Baker
exactly,
would come in and go,
exactly.
Okay, we'll take you.
Exactly.
Sean Baker's 260 pounds, so
yeah, he told me on his podcast, I was on his podcast, he's like, I'm 256 right now, so I'm good. And I'm like, I think we would make an exception for you, brother.
Okay. And
so you're decreasing your risk pool. How about are there any other issues, like say I want to get a transgender surgery or something like that, or a breast implants and those kind of things? Are there limits to what you're funding as far as risk pool?
Yeah, there is. I mean, all the cosmetic stuff, we don't do the cosmetic stuff, which the transgender surgery would fall into that.
Mm-hmm.
We do, so things like that. We're not doing any of the reproductive stuff. So clearly abortions are not paid for. We're not helping fund fertility related stuff. Those types of things.
Was infertile. So if somebody was infertile, they wouldn't be able to crowdsource that.
Well, we wouldn't crowdsource in vitro. That's not something that's eligible currently for funding.
Yeah, because the cost is so exorbitant, and a lot of times when you're metabolically healthy, is not an issue.
Yeah, but I mean, you could negotiate that. So there's a huge spread there too. That's why I wonder why it's excluded.
Yeah, I don't know a whole lot about it, to be totally honest with you. It's one of those legacy rules that we just haven't. Mm-hmm. We haven't. If enough people approach us and be like, "I'm really pissed off about you guys not having X, Y, and Z eligible," then we take another look at it. And we have done that in the past and have changed some of those things to open it up a little bit. The latest one, and I don't know if I buy into it or not, but like, we had so many members want to do like acupuncture for some of their health related issues. And so we opened up acupuncture for some of that. We originally weren't allowing home births because I just didn't understand them. And now 40% of our births are done at home versus 1.6% with the national average. So it's, 25%, our 25x the national average in terms of home births within our community. So, if the community members want things, then we'll definitely take another look at it and see. And we change our member guide once a year to allow for more of those things, just depending upon what they want.
Yeah,
I think the goal here though is like, I don't want to be eligible for everything. It's one of those things where it's like, if it's eligible and everybody does it, then you might as well just pay for it on your own.
Well, then you're gonna have to,
right?
and you're gonna have to increase the cost for everyone else to cover those things, and that's
exactly
how companies like CHM, Christian Healthcare Ministries, or Medishare, things like they limit their risk pool by saying there's certain things we're just not covering, and if you get drunk and total your car and kill 3 people, we're not covering that. That's a poor choice on your part. So everyone else shouldn't be responsible for your being irresponsible.
Yeah, I think it's just a push towards personal responsibility, and I think we've outsourced our healthcare and outsourced our responsibility for our healthcare to health insurance companies and governments for too long. What we're asking people to do is take personal responsibility over your own health, and if you do, then we'd love to have you join us. And I think that's a reasonable thing. And we've seen people, once they've joined the community, like have refocused on their health. And we've actually we had one guy who was like 300 pounds. So he was above the 260. He got below 260. And then he sent me a picture a year later of him and his wife in a triathlon. And he's like, thank you to CrowdHealth, because I never would have done this without you guys pushing me to get there. And I was like, wow, that's amazing. Like, I don't know, I'm sure we did anything like specifically except just put it in an incentive system where it incentivizes people to get healthy, which I think we need more of.
Here's my fear, right? I have an attorney for a wife, so she's programmed. So I get cancer, right? I get cancer. Or you know what? I get an injury and now I gained weight. Now I'm obese, right? Can Andy kick me out? Can he kick me out if he wanted? Is there any regulation that prevents Andy from kicking me out?
We've never kicked anybody out for anything like that.
No,
and nor can we.
Is there any like guarantee, or I don't know the industry.
In our member guide, we specifically say we cannot kick you out for a specific health event. So it gives people some reassurance that we wouldn't kick somebody out because they got a big health bill that we don't want the community to pay. And in fact, look, again, it's back to the incentive systems. I have no incentive to kick people out because they have a big health bill. It doesn't impact my, profitability. I'm still getting my $55 a month from that person, and I want that $55 a month. On the other hand, if they go on, X and say, I can't believe CrowdHealth kicked me out when I have a big, health event, that would be the end of my company probably. And so I have no incentive to kick people out. And in fact, when I get cancer cases, like, we're all over it. I hate it for the person, but I love the fact that our community can help out these cancer cases. I mean, I think we have 36 cancer cases right now that we're dealing with within the community, and these are breast cancer and colon cancer and non-Hodgkin's lymphoma and some nasty ones. And I love the fact that I can come out of this, and then they're our biggest advocates. We're actually doing a documentary on one woman who had breast cancer and went through hell. But, CrowdHealth was there to help her. And so we're doing like a little 8-minute mini documentary to let her, walk through her story and say, hey, CrowdHealth actually loves you really, really well through this. And so instead of fighting your health plan to get your bills paid, we're on your team and your ally fighting for you to get these bills paid. And that's the difference between us and health insurance. So, we've had some people go through some nasty ones.
Yeah, and you also raised the point, because I asked you the question, like, what happens if someone says, I'm not paying the $140 extra, I'm not paying the $80 extra, whatever, and you go, yeah, no problem. But when your need comes around, other people are going to look, oh yeah, they can see if you've donated right to other people, and you go, you haven't been a good community member, like, we're not going to help you out now, type thing, right?
Yeah. I mean, we've had 20,000 bills submitted to the community and got paid. 99.8% of them have gotten fully paid. The 0.2% that didn't get fully paid are from the people who were takers and not givers. So in my previous example of Tro breaks his arm and he submits that bill to the community, what we see about Tro is the last 10 times he was asked, did he say yes, 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 yes to others? Or did he say no, 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 no to others? And so when the community members see that and Tro says yes, 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 they're like, yeah, man, he's been a great member of the community. If Tro said no, 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 he's like, man, I'm not going to give money to some guy who's not been willing to give other people help in the community. And so it's this reciprocity engine that drives the economics of this that has worked, like really, really well. Like I said, 0.2% of bills haven't gotten paid. And all of those have been from people who have been takers and not givers.
Can you tell me about those takers? Like, what if, he was overseas fighting in a war, or I don't know, like how do you determine, who's a taker?
Yeah, it's just the last 10 times that we've asked, we just show the community exactly what they said the last 10 times. So we don't know any of the details behind that.
So like, let's say I'm, deployed in wherever, how does that, and I didn't even respond.
You still pay your phone bill, you pay all your other stuff. It's part of your responsibility, I think. That's
you can actually also, the other thing too, is you can automate the responses. And so if you don't have to actually go in and say, click yes. You can say, hey, anybody who's a giver, I'm going to say yes to. anybody who's just a taker, I'm going to say no to. You can actually set those settings in our system so it'll automatically respond, as opposed to you having to go in and say, yes or no. And I only ask you once per month, and so it's not like I'm asking you every day. It's pretty low activity on your end to be a member, and you can automate all of those things. So we've not had anybody who've said, oh, well, I forgot or anything like that, because all the settings in there allow you to automate some of these things. And so we just haven't had that situation. I'm sure there's situations, these outlier situations where we might be like, okay, I get it. You're in Afghanistan in the middle of nowhere or something. I mean, I don't know. Like, we just haven't had anything like that. And those are all kind of like fringe, outliers that we would probably deal with as we go. Just like the 260, right? There's outliers to that 260. Sean Baker is 260 or whatever. And he's clearly somebody I want to be a member of our community. And so we would make that exception for them.
You ask like the people, hey, we noticed that you're taking, do you ask them why they do that or why they don't give? Or I'm just curious what's like the common responses.
Yeah, I mean, we give them it's 4 or 5 different options when they say no, and it's I don't want to pay for this specific procedure, and a lot of times we have some of the older people who don't want to pay for pregnancies because they feel like that they shouldn't be paying for things that they're not going to utilize. It's silly to me, whatever. 2 is I'm short on cash this month, and so I'm short. I can't pay for it. I don't know what the others are, but those are the 2 primary drivers of these things.
How about
and if you're short on cash and you say no like once out of the last 10 times, then people again will still fund you. It's when you say no 3, 4, 5 times out of the last 10 that people are kind of like, okay, like, come on. So there is an ability for you to say no once every basically year. And without there being, what seemingly there hasn't been an impact if you've said once per year, if you have a short month or something like that.
How do you work with like small businesses, like employers? Do you have group rates or anything like that, or do you do that with small businesses?
Yeah, I mean, so there's a couple things here. One is once you get into small businesses, it's hard because of ERISA, all the ERISA rules around this. So if you're contracted directly with the employer, there's just all kinds of regulatory scrutiny that happens that we want to kind of steer clear of. The other thing is just like maybe a moral roadblock for me, where I just don't think our employers should be in our healthcare decisions. Mm-hmm. And so, it's been one thing for me. It's like we've been growing so fast and just going direct to consumer that we just haven't gone after employers. However, the employers that we do work with, they come to us and they're like, hey, we want to offer something to our members. And we say, we would be happy to give your employees a CrowdHealth, presentation. And then why don't you, instead of paying for their healthcare, just give them a healthcare stipend and let them do with it what they want. And we hope they join CrowdHealth because we think it's the best alternative for them. And oftentimes the majority of those people end up signing up for CrowdHealth. But these are typically businesses that are 20, 30, 40 employees. They're below the $50 or the 50 employee cap that ACA requires them to provide health insurance after that. So we do work with a number of small employers, but it's actually our contract is directly with their employee as opposed to the employer.
Yeah, that makes sense. The employer is giving them a month for that, and then those are all. I was just thinking about how you best work with our patients, because those are concerns. And then the other question I would have would be, what about routine health screens like colonoscopy, mammograms, things like that?
Yeah. I mean, those are a subject to that $500, initial, commitment. So, colonoscopies we can typically get for $1,000 to $1,200. So, the first 500 you own, and the rest is submitted to the community. Mammograms are under $500, and so those are typically borne by the member. But again, what I'm trying to do is get prices so low that they're saving so much that the money that they're saving they can use for whatever healthcare services they want, to give them maximum flexibility. My wife went and got a mammogram just yesterday, and it was $200, and it's just like, okay, you can come up with $200 for a mammogram.
Yeah, exactly. That's kind of how we look at it. Like right now we have CHM, and it's like that. You go, you just pay whatever cash and whatever you need to get something cut off as your skin or something like that. You go, okay, I'm not even gonna. It's not worth the hassle of submitting.
Yeah, exactly. And you look, other insurance, right? Like we talk about this all the time. Your car insurance doesn't pay for your oil changes and your new tires and your windshield wiper blades and all this kind of stuff, right? And so it's like, let's save this for the bigger stuff, and the little stuff you can take care of.
Yeah, especially with the money you're saving from having these other plans. How do you stack up if you're comfortable talking about against like CHM or Metashare or things like that, which are kind of doing a similar thing? How would it be in someone's interest to switch from one to the other?
Yeah, I mean, I asked my inside sales guy actually this morning. We have at an all team meeting. I was like, "Hey, tell us what you're hearing." And the first thing he said is, "We're seeing a lot of people on Metashare and CHM come over, and we convert those almost at 100%, because the rates for those two health shares specifically have gone up so much over the last couple of years that our rates look significantly better than theirs.
And the deductibles gone up. Certain things have gone up. Yeah, exactly.
And our back end technology, the way we do things, is just way more tech enabled than what they are providing. And so I think we stack up really, really well when it comes to the health shares.
Why do you think the health shares are going up in price over the past 5 or 10 years? And how will you battle that to keep the cost down?
Yeah, I mean, I'm going to try to refrain from
the same incentive, right? Like they got a very similar incentive. Let's keep costs low. Let's keep people healthy. Like the incentives are almost exactly the same.
I'm not sure they are. I think there actually is they take a margin between what they bring in and what they kick out. So total. If we were looking at health insurance plans, like premiums minus claims is what they take home. And so I think there is some incentives there that are a little bit different than the way that our incentives. Metashare is on a multi-plan network. So Multiplan, which is the same plans that a lot of these health insurance networks are built upon, is the same network that Metashare is using. And so they're getting pricing that is similar to health insurance pricing. And so, I just don't think, being on a network like that, which you're acting basically the exact same as a health plan. And then, for some of the others, they're directing them to places that are way more expensive than what they should be directing them to. CHM basically goes and lets people go and get service wherever they want, which is great, but there's no navigation component of that to get to people to a lower priced alternative, a lower priced option. We ask all of our members, if you're going to go get a big procedure, bigger, greater than $1,000, we ask that you call us so that we can actually find a low cost but really good provider within your city. We had a member to tore her ACL playing pickleball, a year, 18 months ago, something like that, and went to the hospital. And the hospital, of course, directed her to the orthopedic surgeon that's owned by the hospital system. And that was a $24,000 procedure. And so she calls us. She's like, they just quoted me $24,000, and we're like, hold on a second, let us look around. And so we looked around and we found another guy who actually does a lot of the knees or the joints for the University of Texas football team, and he was willing to do it for $11,000 at a surgery center as opposed to the hospital. And so we were able to reduce that price by 50% by just looking around and finding alternatives within that city, primarily with independent docs who are out on their own, who really want more cash pay patients because they want to rid themselves of the health insurance billing fiasco that currently is a huge component of their business. So we can typically find significantly lower prices for these procedures. And, we ask you to do one more step up front, but it saves you on the back end from having to deal with, escalated prices. So I think we just do a hell of a lot better job of navigating people to lower price procedures than some of these health share does. And I think it's because we're tech enabled. we've got 20,000 members or 20,000 bills now where we've collected all of that data. We know the doctors, we know the prices. And so if somebody else comes for an orthopedic surgery in Austin, Texas, we know exactly where to send them. We know what the price is going to be. And we have a relationship now with that doctor. While it's not contractual, he still is like, please send us more people. And so we've got that database that's growing day by day as we have more and more of these bills come in. And, some of these other health shares are not taking advantage of the data that they have and, the prices that they're receiving. So I just think we do it better, candidly, than some of the health shares.
And what's your, from a physician standpoint, if I'm that orthopedic surgeon, I'm charging, that price. How long will I have to wait to get paid?
You get paid the day of the surgery.
Oh, awesome. So, okay, cool. That's what I was wondering because, and that's the thing is a lot of doctors like, I remember we had like Medicare would pay like 3 months later. So you're struggling, you're waiting for money to come in. And so, that's why under Obamacare, that's why, a lot of surgeons, I would try to send my patients over and they go, we can't take them because they couldn't confirm that they had insurance on the day of surgery. So they were getting stuck with these huge bills going, look, we're losing, we can't go after that patient for that. Like we're out, like whatever, $11,000.
You're getting paid day of, or maybe even before the surgery. So you don't have to float, 3 or 6 months worth of bills to a health insurance plan. You get paid the day of, with a credit card or a ACH. And, it's super easy for the doctors then they don't have, I heard, what my orthopedic surgeon friend told me is that he's got 2 billing people per doctor in his practice. And he spends, a day or two a week just fighting with health insurance plans to get paid. And, whether pre-auths or, if somebody got declined or whatever. And he's like, man, if you pay me in cash, that gives me 2 days a week, a day or two a week of my time back. I can do more surgeries. I can make more money. I'm way more efficient. I'm doing stuff that I love doing as opposed to stuff that I absolutely hate doing. And so, getting these doctors paid in cash. We have dozens of doctors every month reaching out to us being like, will you please send us members? Will you please send us patients? Because they want to get paid in cash.
Do you have a network for doctors? You go, hey, you're in whatever state, here's a doc that's in your neighborhood who knows who we are. Because a lot of doctors just say, no, we don't know who that, we don't know them. We're not taking that.
Yeah. We don't have a network per se, but we do have a database. We have a database of doctors who have reached out to us and said, I want to be, if you have a member in my area, I'd love for you to refer them to me. And here's the prices that I will charge. And, typically we ask for like the top 20, if you're an orthopedic surgeon, 90% of what you do is in, 10 probably, different types of surgeries. And so many of these surgery centers are actually putting their prices online. So Oklahoma Surgery Center, or Surgery Center of Oklahoma, I think is what it's called, puts all their prices online. And a lot of these surgery centers, do that. So we've collected all of those too. So we've just got a huge database of prices and doctors in which we can get people to that are, again, significantly less than what the health insurance plans are paying.
Are there any states where you can't provide coverage?
There are no states that we can't provide coverage. So we have all 50 states, Puerto Rico, U.S. Virgin Islands. I would say there are states that are harder for sure. The Pacific Northwest, for example, is an oligopoly of hospital systems there. And so they just ramp up prices. Wisconsin is really hard. If you get hurt on the western slopes of Colorado, you're totally screwed because there are just no doctors there to take care of you. And so there are places within the country that are more expensive than others. But vast majority of the time we can get you to, a great doc at a reasonable price.
Awesome. Did you have special rates for, I know you do a special thing for carnivores, like a carnivore plan, or you did?
Yeah, we've got a carnivore crowd. So we're trying to create a crowd of people who are low carb eaters. And you have to have fasting insulin and visceral fat markers that are within a specific range to be able to be in that community. And so in essence, what we're trying to do is build a super hyper metabolically healthy community to see if we can get costs down even lower. So while we call it the carnivore community, it's actually more like a low carb. I'm more keto myself, but I would be eligible for that crowd.
I'm just curious, so you got to get them fasting insulin, you got to get them DEXA scans. You mentioned DEXA scans being one of these routine things. They're not easy to get. I'm curious how you're sourcing these nationwide.
Yeah, I mean, most of the time in metropolitan areas, they're there and they're not expensive. And so we've not had a lot of trouble. I mean, there's some parts of the country where we've had some trouble getting people to DEXA scans. But if you don't have a DEXA scan, you can always get your fasting insulin done, and you can do that pretty much everywhere. And so you have to do one of the two to be included. I think they're, Tro, you're the metabolic, expert, but I think they're both pretty good proxies for metabolic health. I mean, not either one of them are perfect. I'm not saying they're perfect, but they're pretty good proxies. And so if you can get one of those two, then we'll allow you into the community. We're gonna introduce VO2 max as an option for people too. If you have a really good VO2 max, we'll give you a discount. And I'm trying to get my people internally to have some kind of assessment of strength, given that we know muscle mass is a significant indicator of longevity. So I want to do squats. Like if you can squat 1.75, times your body weight, then you can get some benefits of that, or pull-ups or something like that. Like I want something that shows that you are, you have the strength component too. But I'm debating internally with my team. They said that's too much of a masculine thing to be measuring. But we'll see if I can get that over the finish line.
Well, it sounds like you're doing a good job of looking at, okay, what are the markers that we're going to decrease the risk, right? Where we're not going to pay out. And so looking at things like that, a lot of insurance companies, they're not looking at those. No one's looking at fasting insulin. I know the big HMOs, you can't even order one. They won't even do it.
Yeah.
So when you start looking at these markers, you go, okay, clearly these markers make a difference in long-term outcomes and longevity.
Yeah. I mean, we're looking at HDL and triglyceride HDL ratios and things like that. We're just trying to make things easy for people. So I'm guessing at the end of the day, there's gonna be 4 or 5 of these biomarkers that if you hit, at least 2 of the 5, then you can get your discounts. We're still, kind of whiteboarding it internally.
Troy, do you have any more hard questions, man?
No, I
give me the hard ones. Those are good. Those ones were the good ones.
No, I think that's the big things I think about is, well, there's gotta be, you're a systems thinker. So immediately the way I'm thinking is, what are the stress points of the system? And I think the stress points of the system would be, acute disasters. So let's say you had a lot of gosh, I don't even want to think about the terrible things, but let's say you had a big,
mass casualty event.
Yeah, mass casualty events. This would stress the system. I think, but
it's going to stress all systems.
Something like North Carolina, if you had a lot of patients there. So things I'd be thinking about in your case, and maybe I'm wrong here, is really spreading out as much as you possibly can to limit any sort of geographic risks. Localization risks. And then the other thing I'd be worried about in you is if something happened all at once. I think that's going to put strain, on your members. And if it
happens all at once, it's happened to all hospital systems and all healthcare. So, you have to look at it that way. You go, what's the odds of everyone in the United States getting, AAA, for instance? Not everyone's cars break down the same day. You hope like someone's car break down, you get other people to take care of their cars. And so I think that's what in direct primary care, that's what we're doing. We're betting. As a matter of fact, one of my favorite patients I just met, she came to me and she's a little bit older. And she said, you know what my hope is? And she's like, I hope I never get my money's worth out of this. Meaning, right? I don't want to get my money's worth. That means I'm sick all the time and I'm all kinds of, I want to see you once a year, do my annual exam. If I need you, you're there for me. Right. It makes sense. Like if you think that way and not think like, oh, I hope I'm like, I don't call AAA every day and say, hey, my car's still running fine. What should I do with my oil? You just go, I don't need you. But if I call you and I break down, I want you to be there to pick me up and not leave me in the middle of the desert somewhere.
Yeah. I mean, the same thing can be asked into a DPC doc, right? Like if you have a panel of whatever it is, 400 or 500 people and they all show up at the same day, you're not going to be able to serve them. But the probability of them showing up all 400 at the same day is almost next to nothing unless there's some mass casualty event where the entire system is going down, right? I mean, it looks a lot more like automotive where you have all these kind of dispersed assets in geographies all over the country that one thing is probably not going to have a tremendous impact on your overall number of bills. I guess with automotive, you can still have a massive flood that takes out all the cars and things like that. But even that case, it's like we're in a better position on that it's just not going to happen. If you can think of one, I'd be happy to address it. But I've been thinking a lot about that, being like, what could take down the system? I can't figure out anything.
That's exactly what I was wondering what you think about it. I've thought about it for like.
If it gets to that point, then we got bigger problems.
You've been thinking about this for years, so I'd imagine you've put more thought into it. But it struck me. The other thing that struck me is because we've had conversations over the last couple of years, Andy, about ways to work together, and it's interesting. If you look at me in my practice, I actually want the sickest people.
Yeah.
And the reason why I want the sickest people is because those are the people I can most impact. And when you really learn about people who are unwell and you get them to a place that are better well, I think the level of appreciation is there, and they see the value in the outcome change. And when we go to these employers, it's the exact opposite. It's like we want the sickest of the sickest because we can demonstrate the biggest value.
Yeah.
Interesting, your model, which I think is just as much needed, is how do we keep really healthy people healthy? How do we reward them and keep them healthy, right? So I'm thinking about how to reward the sickest of the sick. It just seems like you're rewarding healthy people to be really healthy as best as they can, and then accommodating sort of the what happens in life as best as you can.
I think it would be interesting if folks like you could be the on-ramp for us, right? You've got these sick people, you're going through your process, you're getting them to a healthy point, and now you have an additional incentive to be like, look, now you can pay way less for healthcare going forward now that you've gotten to the point of health. And so we're actually incentivizing you to get to that point. It would be really interesting to see your patients, if they would even be interested in having something like us, because I would imagine you get them to a place where they would be eligible for CrowdHealth. And now we can cultivate them and that lifestyle choices by education and additional incentives and additional tests and things like that to keep them on that path, as opposed to throwing them into a health insurance system where I'm assuming some of these people fall off the bandwagon. I don't know. There's something there for sure, Tro. And I think what we're trying to think about is like, how do we build like a core foundation of really good people who want to be a part of our little system, and then start stacking things on top of it to allow for us to expand the number of people that we can get to. And I think what you're doing missionally is, just as important, if not more important than what I'm doing, because I think that,
Andy, you know what? Let's do this. Let's figure out a sick person's, crowdsource. That's something I'd love to tackle, man. How do we take the people who are most in need and get, fix that spread? Because I think the spread on that is bigger than any other spread.
Well, what I was thinking of is like, hey, why don't we have, again, an on-ramp that says, look, you can be eligible for CrowdHealth. We'll just call it CrowdHealth Sick. I'm not sure what it's called. They are metabolically unhealthy or something. You have to go through the process with Tro for, I don't know how long you keep them on your service. I'm making up numbers here. You have to be, for the first 6 months, you have to be on with Tro. Your price is going to be a little bit higher for those 6 months because we need to pay for Tro. And then you have to, within those 6-month period, get to X, Y, and Z metabolic health metrics. And then you can be markers. And then you can be a part of the crowd at the regular crowd rate, right? And so there's kind of a pre-crowd health component to this. Well, if they get hit by a truck, if they on any of these things, they can be eligible for those things, but you're paying more because you have the Tro, special medical weight loss or whatever metabolic health program.
Do you have a lot of people you turn away?
Not a lot.
No. Okay.
The most we've heard people we turn away are smokers. So you're a smoker, and we just don't allow smokers. So that's our number one. And
you check for that, I'm guessing, right?
And Andy,
well, If you have a big health event, we pull your medical records, and it always shows up in your medical records if you've been a smoker. You've told your doctor you're a smoker in the past. If you're a smoker, it definitely pops up.
Oh, if they've smoked ever.
Well, if they've smoked on a consistent basis for over a year, then we don't allow them in the community. And the reason for that is once you stop, the average time you get lung cancer is 18 years after you stop smoking. So you can be like, I haven't smoked for a decade. And I was like, well, you're in the prime time of getting, lung cancer, even though you quit. Cardiovascular disease, from what I understand, drops off to almost about, average after 10 years, your body recovers. But lung cancer is one that stays with you for a long, long time. So we just say no to that. We're re-looking at that to say, hey, you can join, but if you get lung cancer, then that's not a part of what you can get funding for. We're trying to figure out how to allow for those people who've made, better health choices now than in the past, but we're batting that around internally.
And how about is it the price is not based on age too? So if you're 64 years old, you pay the same as a 28-year-old?
55 to 65, you do pay a little bit more than the singles under. Yeah.
And then,
then 65, we can't do Medicare. So you pop off into Medicare. Unfortunately.
Yeah.
Although we're coming up with a Medicare, it's something that you can use while you're on Medicare. We just haven't got there on the regulatory side yet.
Yeah, and that's one of the things I hear, people say, well, I'm paying $1,400 a month for Blue Cross PPO. Like, I'm paying all this money for insurance. Why should I pay you too, right? But the reality is, like, if you went on a cheaper plan like this, it's a no-brainer how much money you're saving every single month. Even if you get hit by a truck a couple times a year, you're still saving money in this kind of system. So it's hard for people to get that past them. So it might be even cheaper for you to get outside your employer's terrible insurance because you're paying your huge copays and all this stuff anyways. And so when you start looking at the overall cost, you go, it's a no-brainer to have Cadillac Care or Lexus Care or Tesla Care at a super cheap price. It's ridiculous. Like, what do we spend $100 a month on?
25% of our members have declined their employer's plan and jumped over to us. So it's about a quarter, and we're seeing more and more every year as these employer-based plans are going up so much. These employers are starting to have to push down more of the expenses to the employee. So the employee portion is going up, and therefore we're at an inflection point where most of the time we're just at about the same price as what the employees are taking out of their paycheck every month. And we don't have the huge deductibles that you have with some of these health plans. So we're starting to see an inflection point.
And the other big issue for an employer is this: if you have good healthcare for your employees at a cheaper rate, those employees, they're not going to be calling in sick as much. They're not going to have so many doctor's appointments, all these things that people don't realize, all this the FMLA stuff where they're, I got to go see my psychiatrist 6 times a week, and all those kind of things. That's a cost to the employer for sure. And having sick people call in sick or coming in late or being hungover or whatever, having healthier employees is a huge deal like that. They don't realize how important that is.
Yeah, agreed. Well, my family saved about $15,000 last year with CrowdHealth versus if I were to go to a healthcare.gov plan. And I think, most of our families are seeing somewhere between $8,000 and $15,000 saved, which is really, really significant.
That's a few ribeyes, Tro.
Yeah,
that's a few ribeyes.
I got one last one before we part ways here.
Far away.
It's I think the biggest thing here is, like, let's say me, right? Or let's say a family member wants to join and they qualify, right? But they're like, I want to bring my whole family in. I got 3 kids. I got 2 kids. Now, one of the kids maybe is obese, right? Or the wife has a pre-existing condition. How do you guys tackle that sort of situation where they're like, they're good, but the family's not so good?
Yeah. For the kids, we don't look at obesity for kids. If you're under 18, we don't track that. And it's not a perfect thing, but just for simplicity, we don't track the kids because that usually tracks pretty well with the parents. And then, if one of the parents is doesn't have pre-existing and one does have pre-existing, and then they have to just decide, like, do they want the parent without the pre-existing to jump on? Are they going to save enough money to pay for the pre-existing? Then it's a family decision. So, we have just across the board, here's our pre-existing policy. It applies to everybody. You all can decide how that works, for you guys. And, I would say half the time it goes one way and half the time it goes the other, just depending upon what the pre-existing is. Like if you have thyroid issues, hypothyroidism, if you have high blood pressure, things like that, like typically you can get those generic prescriptions, right? For 10 or $15 a month. Like those are easy on the pre-existings. It's the people who had cancer last year and are worried about the cancer popping back up, that have the harder decisions. We only consider pre-existing in a 5-year look back. So if you had cancer 6 years ago and it pops up and you join today and it pops back up tomorrow, that would be eligible. So we're not looking back, 20 years. It's just a 5-year look back.
And then you cover the cost yourself for 2 years, right? For the first 2 years, and then it would be covered again. Is that right?
And so just depending upon what you anticipate those costs being, you can make a decision. If you're a family of 4, you're saving $10,000, you can be like, okay, is my pre-existing going to cost me more or less than $10,000? And that's the decision that you kind of have to make. So it's not a perfect system. It's one that we're building, that we're doing the best we can with, with the current crazy health insurance systems that we have to deal with and regulatory requirements that we have to deal with. That's a whole nother, piece of the pie that we deal with on a day-to-day basis. But as you imagine, the insurance companies don't like what we're doing. The departments of insurance at these states don't like what we're doing. And so it is a, constant nonstop battle between us and them and our regulatory attorneys and all that kind of stuff. So I'm embarrassed what I pay my regulatory attorney to help us with this stuff. But so far we're still available in all 50 states and anticipate that staying the same.
How about HSAs? Can people use HSAs to pay their premiums?
Not yet, but that might change this administration. Because you have to have a high deductible health plan to have an HSA. And so it looks like this administration is going to bifurcate that. So anybody can have an HSA. And in that case, our members will have access to HSA. So we're hoping for that regulatory change.
Awesome stuff.
Thanks for coming on, Andy. Where do people find
you guys?
They're all in the show notes, and how people can learn more and find out more about this. Models. The existing model doesn't work.
Sure. Join crowdhealth.com. If you use the promo code TRO, TRO, then you get our service for $99 for the first 3 months. Tro doesn't get any back. It doesn't get any money for that or any referral fees, but we just wanted to give y'all. If you can try it for $99 a month, and if you like it, awesome. If you don't, that's great too. But given that you have the opportunity to save $10,000 or $15,000, try it for a couple months and see if you like it. It's a low entry point, and that's why we do that. So join crowdhealth.com and then join CrowdHealth on all of our social media platforms.
Yeah, I get no kickbacks. So just like what you're doing.
You get no kickbacks.
Story. Yeah, I'm not affiliated, but happy that you're tackling something that needs to be tackled.
Yeah, I think for us, it's important because we want to give people options. And you go, look, you hate the system. Why are you paying a system you hate that's not working for you, right? And so having those different options, especially for what we do, have a vested interest because we want people to say, wait, let me look at my entire cost of healthcare. How much am I paying a month for that insurance? What are my copays? What are all these things? And so to have that all rolled into a direct primary care or doing what you're doing, it's like, how do we all work together the best? And this is a perfect model for people who are saying, look, I want to stay healthy. I want to be healthy. I don't want to be like in the doctor's office every week. How does that work for me? And I think that's a huge thing because you have to realize, everyone listening, you're paying for this huge pool of crazy stuff that the health insurers have to pay for, right? And you go, why do I have to pay for these things I don't believe in, right? And so I think, putting yourself in these kind of plans, you limit how much you're paying in to cover all of these other things. And I think it's really a great move forward for medicine and for people who are struggling right now, especially when you're paying more for gas and eggs and whatever we are. So wherever we can help
sign
out.
You up as my sales guy. I'm gonna sign you up.
I'm gonna talk to I'm gonna make my wife listen to this. I'm like, I was thinking about, I was like, let me switch over. I'm tired of doing some other stuff. So yeah.
Come on over.
And plus, I
Thank you,
have
guys.
I might have your cell phone number. I'll go, Andy, pay for this. No, I'm just
There you
kidding.
go.
Try to stay out of the hospital. So awesome, man. Thanks so much, Turo. Thanks. Good seeing you, man. Have
Thanks,
a good
guys.
weekend.
This is great.
All right.
God bless.
Have a good one. Bless
See
you.
ya.
Bye.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.